what do we do? I find that it's most interesting to know where someone came from to know what they do. So I'm going to tell you how Medic actually started. Medic started in a small rural community called Namatete in Malawi. And our co-founder, Josh Nesbitt, went there as a starry-eyed pre-med student to try to save the world. And what he found instead was that he was in a community of 250,000 people who had just one doctor. And they faced insurmountable challenges, such as having no effective emergency transfer systems, and also having no knowledge of what the current burden of disease was in communities. And the solution that the community came up with, because they didn't have the funding to find an additional doctor, was that they employed over 500 community health workers or volunteers to fill the gap from the rural community level to the clinic level. This should also be one of our co-founders. In the middle, that's Dixon. And he's a 34-year-old Malawian man who headed up a lot of the community health work in Malawi, in Namatete. And he delivered each and every day, or each and every week, a paper form 35 miles to the clinic. And so the aha moment for Josh was when he recognized that a mobile phone signal there was at 6 bars. So he had a stronger signal in Namatete than he did in Palo Alto, California. And so what he implemented was actually a version 1 of Frontline SMS and enabled the forms to be collected via SMS. And who we are today and how we become who we are today is as a result of this understanding. Essentially, I'm not sure, can someone actually stop this? It's advancing for me without, without me wanting it to. No, that's not what I want. Okay, I can go back. Okay, that's fine. So essentially, this has become, okay, so the results after 6 months were that we had enrolled 2 times the number of new patients. We had effectively transferred 150 emergencies, and we had over 1,000 hours of saved time. And that was just the most basic interface of just using the mobile phones to transmit information. And so who we are today as Medic is we're a team of around 20 software developers, program managers, and researchers who design customized solutions for partners that are working in developing countries. We have active projects in 17 countries, and over the past 3 years we've worked with 50 partners. The projects are in South Asia, Latin America, North America, and most of our activities are actually in Sub-Saharan Africa. And the niche and the problem that we try to solve is that in a world of over 6 billion people, there's still 1 billion people who will actually never see a medical professional. This is a really beautiful image from one of our projects in Nepal. And you can't quite make it out, but on those mountains are covered with what's called shale rock. And I'm a rock climber, and those are the absolute most atrocious rocks to climb. But in each of the 6 clinics that we work in, we have, again, a full 6 bars of mobile coverage. And so the work that we do, this is what's called a mobile-enabled workflow, is that we work with partners on a one-to-one basis to identify the needs, the breakages in communication that they have, and then the opportunities for SMS-based or app-based solutions to improve their outcomes. We work with use cases like stock monitoring, reminders for patients to come to appointments, and then we also worked in disaster situations like Haiti to help improve access to care for patients who are disconnected. Usually it's better just to talk about what you've done and how it's worked. And so I'm just going to highlight a use case that we've recently started to study in our project. Hello? Okay. So in the communities that we were working in India, we implemented a really basic SMS-based reminder system for mothers and grandmothers in the homes of children who were enrolled for immunization. The structure of the protocol was very simple. Basically, a reminder would come to the mother or the grandmother 3 days before the appointment saying, your child needs to come to the clinic at this time for this immunization. The baseline for vaccine coverage in the community was 60% when we started working there. And after 6 months, we were at 95% of coverage. And then at 13 months, we've actually improved vaccine coverage to 99%, which is an incredibly compelling story to tell. The power of an SMS is actually quite difficult to quantify. The niche that we fill is providing tools for challenging settings. So distributed web applications, SMS-based technology. And what we recognize is that although, as it's been spoken about today, more and more users are on the internet. In Kenya, for example, there's still 20 million mobile phone users who haven't accessed the internet. In the communities where we work in Kilifi, if I have a training of 100 community health workers, 20 of those workers will typically still not have used a mobile phone. So as much as you can say it's now a ubiquitous tool, it isn't. And we understand that familiar is typically better. The technology that we've created is something called a SIM app. Does anyone here know M-Pesa? Yeah? And that's also a SIM app. It's basically an application that runs off of a SIM card. So instead of needing to find and buy a shiny mobile app or a shiny Android-based phone, you can use our tools on absolutely any device that has a SIM card. And this is what it looks like. It's a wafer-thin microprocessor that allows you to load structured data collection onto any SIM running phone. And you can see there, those are our data collection tools running off of a tablet, an iPhone, and then finally a really beaten up Nokia. And so what we argue is that although the world is moving mobile, it's moving internet, it's moving apps, it's moving towards interconnectivity, familiar is still better. The gap that we propose to fill is at the absolute base level of community, specifically the community health worker level. Community organizations still have a great resource to connect to users, to provide information back and forth, and to build structures where there aren't any. This is a picture of the health clinic that we're working in Liberia, and this is a picture of the road leading up to that health clinic. And so we propose that health shouldn't be depending on the weather or depending on the mobile coverage, but it should be equal access to everyone regardless of where you come from or who you are. So I welcome any questions that you guys may have. That's my email and my phone number, and thank you again.